Hello. So I think it's time to start the session. This session is covering a broad range of new methods that will enable us to better understand transmission dynamics and incidence, covering phylogenetics for identifying microepidemics at a more granular scale, testing hypotheses about transmission patterns and identifying early infections, includes methods for key population size estimation at the national level, and yes, we'll discuss further developing new approaches to incidence estimation. So chairing the session will be Daouda Diop, who's the director of Endosante, an international organization based in Dakar, Senegal, that works in 12 countries in the West and Central African region in the area of public health, with a focus on country and regional programs focusing on marginalized population, sexual and reproductive health, and human rights in Africa.
And I have the pleasure to co-chair this session with Elizabeth Firum, who is an epidemiologist, assistant professor at London School of Hygiene and Tropical Medicine. Elizabeth works in sexual and in sexual health and HIV prevention and care on project aiming to understand how to improve health promotion program for female sex workers, gay men, men having sex with men, adolescents and girls in East and Southern Africa.
Thank you. So our first speaker is Dr. Cordelia Coulthart, who's a clinical lecturer in infectious diseases at University College London. Her work focuses on the integration of molecular and traditional epidemiology to enhance understanding of transmission dynamics of infectious diseases and thus inform intervention strategies.
Okay, thanks very much. So I'm Cordelia Coulthart, and I'm going to be talking today about the identification of a new microepidemic in rural South Africa and how this was detected initially by molecular epidemiological methods. This work provides a case study to show the utility of how molecular epidemiology can supplement traditional epidemiology and enhance it in surveillance methodologies. And we believe this work is one of the first examples where public health measures could have been implemented on the basis of molecular data. So the overarching theme of this work was to explore the utility of combining traditional epidemiology and molecular epidemiology in understanding transmission dynamics of infectious disease outbreaks. Traditionally, we've used classical epidemiology, which is a bedrock of surveillance techniques, and it provides data on which public health interventions have been based historically. And while it's fantastic and has led to many advances, it is associated with some limitations. So it only tells us in a population who is infected. It doesn't tell us about how the transmissions happened within that population. And phylogenetics can give more granularity around that. It can tell us a bit more about the transmission patterns and linking those people with similar viruses. So if you've got a population and you test the people in the population infected, and you can get the genetic sequence of the virus, by comparing the similarities of those sequences and assuming those with more similar virus are more genetically related and more likely to be closely related in terms of the transmission cluster, you can begin to build up a tree of how transmission has occurred within those people you've tested. And this is a phylogenetic tree showing you the clusters. So it allows you to see potential transmission links. And with increasingly genomic data being available, it can be used to provide a different angle through which to understand transmission dynamics. However, it's also associated with its own limitations, including that it doesn't always represent the true underlying population. So I've talked about the background and rationale, and now I'm going to go on to the case study as an example. So the specific objective of this work was to understand the role of migration and microepidemics driving the sustained transmission of HIV in a highly endemic area in South Africa. And this is an area with universal testing and treatment. So we were looking at how phylogenetics can enhance traditional epidemiology. Specifically, is there sustained local transmission ongoing in the area, or is it as a result of multiple external introductions? And why does this matter? Well, the different strategies and different drivers might influence the public health interventions that you put in place. So the study area is the Africa Health Research Institute. It's a demographic surveillance site about 3 hours north of Durban in rural KwaZulu-Natal. investigating a population of about 90,000 people. And one of the key things is that this is population-based data. So there's linked HIV testing and sequence data with epidemiological and demographic data. So it really provides a unique and fantastic resource to undertake work like this. It's an area of high HIV prevalence at 29% and characterised by very high rates of unemployment, so about 68%, and high rates of mobility at around 37%. And this is the study area here. And within this area, the treatment as prevention trial was undertaken, reported last year, that showed universal testing and treatment did not decrease incidence in the area. So as I've said, we undertook a multidisciplinary approach to understand the transmission dynamics in the area, so looking at an organism level using phylogenetics, a population level using the epidemiological data, and then the social ecosystems that might influence both of these. The phylogenetic work, we constructed a maximum likelihood phylogeny, so around 2,200 HIV subtype C pole sequences. Approximately 1,400 of these were local RE sequences from between 2010 to 2014, and 800 of them were control sequences from the rest of South Africa. For any cluster we identified with more than 20 sequences, we did a dated phylogeny using a program called BEAST2. The epidemiological work was led by Frank Tanzer, and I think you've heard about this in a separate talk earlier this week, and it calculated HIV incidence in the area. He also undertook geospatial mapping of the HIV incidence and used Tango's flexibly shaped scan statistic to identify new clusters. And the social science work was undertaken by Mariam Shamanesh and Janet Seeley, and it involved an ethnographic assessment of HIV risk and prevention landscape. So this is the phylogenetic results. This is a phylogenetic tree, and I showed you one earlier, and this is circular due to the size of the tree. The red sequences are those from RE, and the blue sequences are the control sequences from the rest of South Africa. And there's three main things you can see from this. Firstly, that it's a very mixed tree, showing lots of mixing between South Africa and the RE population. There are some areas that are more predominantly red that might suggest some local sustained transmission. But the key finding is this cluster here, which is much larger than any other cluster in the tree. It's got 75 sequences, and the short interbranch length suggests that these are very genetically similar, which might suggest recent transmission. And so I'm just going to focus on this cluster here now. We did a dated phylogeny of this, which showed that this arose from a single ancestral source in approximately August 2011, and this sort of pale blue bar is the confidence interval. And it comprises of two outbursts of infection, so a smaller one in 2012 and a larger outbreak in 2014. And when we link this to the demographic data and look at those involved in that cluster in a bit more detail, we looked at those in the cluster and compared that with the demographic data of all of those people we had sequences from in the same time period from RE. We see two main things. Firstly, there's many more men in this cluster, so 57% compared to 30%, and there are also more than double of them in full-time employment. They're also relatively more well off, with a higher percentage in the least deprived wealth quintile, and they have more education. We went on to geographically map these people to where they lived, and we saw that they fell into two clusters. So firstly, 40% of them were around a previously known hotspot. So this is a main highway going from Durban up to Mozambique. And 40% of them were there. However, 40% of them were in this very rural area that had previously been documented to be an area of low incidence and low prevalence. And geospatial mapping also confirmed this. It confirmed the phylogenetic finding of this new high incidence area by the differential space-time in the incidence. And Frank Tanz has already talked about this earlier in the week. When we tried to work out what was different in this area and what had changed, this white area here represents, it's a new mine that opened in 2009. And looking back at the demographic data that showed that there were more men and there were more in employment, that might suggest that the people involved in this cluster are associated with the mine. One of the important things to say is that this mine isn't a traditional mine as you might think about it. It's an open cast coal mine that employs local people because it doesn't involve deep mining. So the people often live in the peri-urban area and are bussed in. It's not a mine where there's lots of hostels around it. It's a very sparsely populated area. And the social data that we had from the ethnographic assessment reinforced this theory because the local people suggested that money and employment had come to the area, and that led to increased risk behaviours such as increased alcohol and opportunities for transactional sex. So in conclusion, our findings highlight the continued emergence and persistence of microepidemics within an existing endemic region, and this can fuel ongoing transmission. These bursts of infection might happen and perpetuate the ongoing epidemic, but they can be difficult to detect. But phylogenetics provides one way of doing this. So phylogenetics is a powerful tool, and it can inform HIV prevention strategies, particularly in the context of having comprehensive linked epidemiological and social data. And with increasingly available genomic data and analytical tools, these methods should be considered, where available, to be incorporated into routine surveillance frameworks. But one of the things to say is if we're going to try and scale this up, we do need to be aware of the very real ethical, legal and social risks associated with that. And there's also some ongoing work at RE beginning to build a framework to address that. Because while this is useful at a population and outbreak level, there are the risks at an individual level and utility are much higher. So that's something to bear in mind and one of the limitations. Thank you very much.
Thank you very much. We have a few minutes for questions now. Yeah.
Hi.
Yes, thank you very much. I'm Mike St. Louis from CDC and PEPFAR. I wonder, with that cluster, if you've gone back to look at it as a missed opportunity for prevention. In retrospect, given how you've been able to look at its evolution, what might have been done, what should have been done to avert that, and is that now being done more generally in this area?
Sorry, what I should have said is I've talked about how the findings might influence public health interventions. So going forward, any opening of a new economic development, whether that's a mine or any other economic development, there is strategies in place to make sure that before it opens, there is good public health infrastructure to identify any outbreaks and prevent this sort of microepidemic occurring. So I think, that's really the key message going forward, and that's the sort of thing that we need to bear in mind.
Is that being done now?
Yes.
Good, thanks.
I think we could have one more question.
Nora Rosenberg from UNC. That was a great presentation. Are you able to link any of the cases in your data set to get at more behavioral information? So not just looking at the demographics of the people, but looking...
Sorry, I can't hear you.
Sorry. Are you able to look at any of the behavioral characteristics of the cohort that in the microepidemic? Like, for example, whether there are age disparate relationships or sort of the nature of those transmissions?
Yes, so we are able to do that, and that's sort of something we're in the process of doing now, and particularly around age, and because we believe in the area that sort of young people are a key population, but I don't have that data available just yet.
Next question.
I said one more, but I think we can have one more question. Sorry.
Yes, thank you. Richard Hayes, London School of Hygiene. Really interesting work. Thank you. We're also in PopArt combining epidemiological and phylogenetic data with some similar objectives. It sort of relates to the last question. So I didn't get a clear picture of whether you think this microepidemic is related to sort of sex work patterns. So there's more men than women. So is the suggestion that this is a small number of women with multiple male partners, which is a bit different from what we often see, I think, in your area, which is male migration and bringing back infection to their female partners in the area?
Yeah, so the ethnographic work suggested that it was sort of linked to the mine, but in terms of bringing money and employment. And I think the thought at the minute that we're studying further is that it might be related to increased transactional sex in the area. So not sort of traditional commercial sex workers, because it's not the hostel structure and the sort of traditional, but transactional sex.
Thank you.
Thank you, Cordelia. Our next speaker is Dr. Olivier Redman, who is a lecturer in statistics at Imperial College in London. Olivier's research focuses on statistical and viral phylogenetics method for characterizing the spread of the epidemic, especially HIV. He's going to share with us his finding on from a recent study from Rikai Health Science program on the impact of hotspots on the spread of HIV/AIDS.
Right. Hi. Hello, everyone. Thank you, Duda, for this very nice introduction. It's a very great pleasure and honor to be able to present to all of you today our findings from Pangaea HIV and the Rakai Health Sciences program. And I have no conflicts of interest. So just to set the scene and to get us going, one of the characteristic features of the HIV epidemic in sub-Saharan Africa, as you all know, is that it's markedly heterogeneous. So there are foci of high HIV incidence and high HIV prevalence, which we all know as hotspots. And critical to current prevention programming is the hypothesis that geographic targeting of combination HIV prevention to these hotspots is essential. First, to substantially ameliorate the broader epidemic and for making cost-efficient use of resources. And if you zoom in East Africa, fishing sites around Lake Victoria are hotspots. And I'm trying to show to you at the with the bottom two maps that the HIV prevalence that we're estimating in fishing sites amongst women was about 40%, and amongst men it was 30%. And since 2014, the Ugandan National ART guidelines recommend geographic targeting of combination HIV prevention to these fishing sites. And this included immediate ART provision after diagnosis. And this test and treat strategy was based on the recommendation, of course, of high HIV incidence on these sites, but also on the assumption that fishing sites are a major source of new infections further inland. And to bolster this geographic targeting and aid this effort at the local level, we set out to confirm this assumption. So this was the purpose of our study. And when we planned this study, we realized that there are in principle two different ways in which fishing sites can seed new infections inland. So first, this was by transmission from individuals who reside in these fishing sites, so direct transmission. And the second mechanism was migration of individuals to inland communities and subsequent spread in inland communities. And so to address this complexity, we used a combination of techniques and data sources that I'd like to share with you in the next couple of slides. So first, the Rakai community cohort was extended to include the 4 largest fishing sites in the area. And between August 2010 and January 2015, we had 19,799 individuals in inland communities that participated and 6,083 that participated in the fishing sites. And that was 99% of those who were present at the time of the survey. Of those, we found that 14% were HIV infected in inland communities and 40% in fishing sites. Now, we also asked whether individuals had taken ART before we saw them, and we found that 67% self-reported no ART use amongst those infected in inland communities, and it was 84% in phishing sites. And it was in 2010 when the guidelines were still recommending ART start of ART at a CD4 count below 500. The second part of our analysis was to reconstruct likely HIV transmission networks with viral phylogenetic analysis. And Pangea was able to sequence 63% of those that were ART naive in inland communities and 74% in phishing sites. So just to give you an idea that our analysis was based on a relatively large subsample of infected individuals. And I wanted to go a bit deeper here because with the deep sequencing, and this fundamentally allowed us to reach qualitatively distinct conclusions compared to standard approaches. So with the deep sequencing, and I'm trying to illustrate this at the top of the figure, we were looking at thousands of HIV sequence fragments per individual. And these reads capture the viral diversity of one individual. And when we put this into a phylogeny, or phylogenetic estimation, you see these clusters of reads that represent one individual. So in the phylogeny, you see these blue dots and the red dots. So these are reads from one individual. And what we discovered is that these clusters usually have a particular direction. So one is first and one is second in the phylogeny. And this ordering gave us a phylogenetic estimate of who is source and who is recipient. And when we validated this against epidemiological data, we found an accuracy of 83.7% in our study, in inferring source cases from deep sequencing data. So this has appeared in several studies by now in the literature. I also wanted to point out the poster by Rebecca Rose at this conference, who looked at HPTN 052 couples using different sequencing, deep sequencing protocols, different methods, but essentially reached the same conclusions in terms of accuracy. So we're quite excited to see this inferential robustness, right? And with that in mind, we are happy to push forward with our deep sequence analysis. Now, the third component of our study was that we mapped households and migration events. And what I'm trying to illustrate with these colors is that this allowed us to interpret the reconstructed transmission networks at a resolution below 50 kilometers based on the additional epi data, while accounting for population movement, which was extensive. So just to zoom into this blue individual that you see at the bottom. So this person was found in phishing sites, but we also learned that he recently migrated within the 2 years before the likely recipient was found positive. And he migrated from outside to the phishing sites. So based on this information, we interpret this transmission event as an introduction from outside, based on this additional migration data. So I'm now coming to the results. In total, we were able to reconstruct 293 source-recipient pairs from deep sequencing data. And the map shows transmission events that started inland and ended inland. And the colors give you an idea about whether the source case had migrated or not. And contrary to what we expected, we found that 91% of those pairs were not between phishing and inland sites. So this should suggest that the transmission networks in inland sites are largely distinct from those in phishing sites. And when we looked further, we only found 7 events from phishing sites to inland communities. Vice versa, we found 3 times as many. So this directly contradicted our initial hypothesis that the high prevalence phishing sites would seed and sustain transmission further inland. Now, interpretation of these unadjusted counts was a bit challenging, and this was because we found substantial variation in sequencing and participation rates. So what I'm trying to show with this figure on the y-axis is sequencing rate, so that's number sequenced divided by number infected, and I'm doing this on the x-axis across communities, and by color, by gender. So you see the substantial variation. And we adjusted for this by using a technique called Bayesian data augmentation. Now, our initial finding on the unadjusted data did not change. In particular, we found that we estimate that transmissions from inland to phishing were 2.7 times more likely than vice versa, as I show in the gray box plot, and this was significant. We also found, in particular, significant differences by migration status. So transmission from inland to fishing was much more likely amongst out migrants compared to permanent residents. So this indicates that population movements are really a key factor that drives and shapes the local transmission dynamics at this very small scale. So with this, I'd like to discuss impact. So our analysis is just a cautious case study, and it shows that hotspots are not necessarily the main sources of HIV infections in neighboring low-risk areas. Now, of course, populations in hotspots will continue to directly benefit from geographic targeting of community HIV prevention. However, the indirect benefits of geographic targeting to neighboring low-risk areas may depend on a case-by-case basis and may be limited. Now, going forward, we think that mapping may not be enough to allocate resources most effectively based on this work. We think the next steps should be a more comparative assessment of hotspots across sub-Saharan Africa. It doesn't have to be that many, but it should be systematically chosen, maybe from South Africa, from Botswana, from Kenya, on their contribution to the broader spread of the HIV epidemic. And we also propose that similar analysis as we have done could help allocation of limited resources more effectively by prioritizing those hotspots for geographic targeting that have a large impact on the epidemic. So with that, I'd like to highlight the many contributions to this study from the Rakhine Health Sciences, program, the Johns Hopkins School of Public Health and Medicine, particularly Kate Grabowski, the NIAID, Oxford University, Imperial College London, Pangea HIV, and especially Christoph Fraser, our funders, but most importantly, the program staff and the study participants with whom this particular work and so many others just would not have been possible at all. Thank you very much.
Thank you very much, Olivier. Now take 2 questions. Yes, yeah.
Great talk, Ollie. Thank you very much indeed. The question is the heterogeneity of mobility, because I think the assumptions that you've made are that either the hotspots transmit to the colder spots or not, and you've concluded the latter. So, but there certainly are some individuals who do transmit. In terms of the sampling you had, did you have the power to identify whether those transmissions were actually associated with larger clusters? In other words, those people who may be accounting for the transmission between these areas are accounting for a disproportionate number of infections?
Yeah, so what I tried to make clear is that, with the design of the study, we specifically oversampled the largest fishing sites in the area, just to really be able to address the question you're asking. If we do this analysis, can we actually see transmissions from fishing to inland? And these are the largest, and there are not many more fishing sites. So the cohort study does not include all inland communities, so that is clearly something to bear in mind, but we certainly had all fishing sites, so to be sure that we see as much as possible from fishing to inland. And there really were only 7 out of 293. So it's really quite striking.
Next question.
Yes, just to point out that the very nice study, as was the previous one, but to point out the obvious that they came to different conclusions, basically, opposite conclusions. Cordelia presented, showed from a transmission from a hotspot to an inland area and a new set of infections, and you didn't. And does this relate to the timing of the epidemic or the epidemic phase, or do you just think that we're just each situation is its own situation, and what are we learning between those 2 studies?
Yeah, no, I mean, this is really a very important question, and as I laid out in the conclusions, we need to work on a more comparative cross-comparison. But just to point out, it wasn't clear to me from the previous conversation whether the hotspot was actually just seeding the epidemic in the mining sites, or whether there was a lot of intermingling or back and forth. So I'd be very curious to see those results and to actually really being able to interpret what you just said. But it does need, as a first step, this comparison to be able to. But to go deeper, we and colleagues in Rakai did a very extensive analysis of population movements between the fishing sites, from where migration occurs into the cohort studies. And we do know that there are substantial population movements of HIV-infected individuals from inland communities to fishing sites, rather than vice versa. We know there's this extensive flow between fishing sites. We've also have ethnographic information that is further supporting this idea that infected individuals come to the fishing sites as a last resort to make a living there. Thank you.
And last question. No? Then thank you very much, Olivier, for this presentation.
Our next speaker is Melinda Judge. She is a PhD candidate at the University of Western Australia, School of Medicine.
Good morning, everyone. Today I'm here to talk about our work using RNA sequencing to identify a gene expression signature unique to acute HIV infection in Mozambican adults. This work has been part of an international collaboration headed by IS Global in Barcelona and in conjunction with the Manisa Health Research Centre in Mozambique, and a number of others around the world, including ourselves at the University of Western Australia. I'd like to begin by acknowledging and thanking the people living with HIV who have generously participated in this research, many of whom were recruited during the particularly difficult time of diagnosis and then returned on multiple occasions in a remote location where HIV is still highly stigmatised. The accurate measurement of HIV incidence, that is the number of new infections in a population during a certain time period, is crucial for epidemiological monitoring, understanding transmission patterns, and to target and evaluate intervention programs, yet it remains challenging. Current HIV incidence tests are antibody-based, so there remains a window period prior to seroconversion that is problematic to detect. Also, the misclassification of late-stage infection as acute HIV is a major weakness with all incidence assays to date. Our cohort was designed to investigate novel approaches for incident assay development, and the component contributed by our Australian group was the use of RNA-seq to identify a transcriptomic signature unique to acute HIV. Our study site was the rural district of Manisa in southern Mozambique. Patients presenting to Manisa District Hospital with fever or those participating in voluntary HIV screening were tested for HIV, and those who were antibody negative and viral load positive were recruited for our study and requested to return for up to 9 follow-up visits over 18 months. Out of just over 4,000 people screened, we identified 85 acutely infected individuals using this method, which gave us a rate of 2.7% of acute HIV in our cohort. It's also noteworthy to mention that our longitudinal study occurred when national guidelines required a CD4 count of below 350 to initiate ART, while now the recommendation is test and treat. We also enrolled HIV negative and chronically HIV infected individuals, both ART naive and ART treated, as controls. So blood samples were collected and PBMCs isolated for RNA sequencing. Feebig stage was identified from the earliest acute time point, and the visit number was adjusted to more accurately reflect time since infection. And as you can see, we started with 29 acute HIV samples at follow-up visit 1, reducing over time to 5 samples at the 18-month follow-up visit. And there were many reasons for dropout, with the most common being confusion, disinterest, or meeting the criteria for ART initiation. PBMC isolation was performed in Manisa, and samples were shipped to Perth, Australia, where the RNA was isolated, and 50 base pair single-end RNA-seq was performed using the Illumina platform. We had on average 23 million reads per sample, and reads were aligned to the human reference genome with over 80% at high mapping accuracy. Normalisation and quantification of read counts was performed using R, and the statistical significance adjusted for multiple comparison. So we have two sets of analysis that I will present, and the first being differential gene expression, as well as the full dataset signature. So firstly, our results showed significant differential gene expression between groups. To orientate you to the table, the columns show the acute follow-up time points, and the rows represent the 3 control groups. So the data is presented as the number of differentially expressed genes between each acute time point and each control. As you can see, highlighted in grey, a large number of significantly differentially expressed genes are present for the first 4 time points when compared to HIV-negative controls. Altered gene expression during acute infection is expected, but the number of significantly affected genes is very high, with 3,873 altered genes at time point 1. And surprisingly, the gene expression levels at the 5-month follow-up time point and beyond stabilised compared to healthy controls. In the next row, altered gene expression is large and consistent for 12 months, but compared between acute and chronic with ART controls. This difference has been observed previously in studies using paired samples before and after ART initiation, but not before in a longitudinal study. And in the last row, significant differential gene expression occurred for the first 3 follow-up visits between acute and chronic without ART controls, and this shows the heightened level of dysregulation during acute infection. And for these highlighted time points, there were 15 genes with mean mapped reads that show consistent differential expression that distinguishes acutely infected individuals from all 3 controls. And here are those genes. As you can see, the x-axis is time up to 18 months since recruitment, and the y-axis is mean mapped reads per gene. Acute HIV is represented in black and are all highly overexpressed in early infection, with a gradual decline across time. As the control groups do not have follow-up time points, their mean mapped reads per gene are indicated as a constant line, with uninfected controls in blue, chronic with ART in orange, and chronic without ART in red. And of the controls, the chronic without ART has highest expression of these genes, as indicated by being the highest constant line on the graph, and therefore over time quickly become the most difficult control group to differentiate from acute HIV. And so what do those genes do? So highlighted in blue, 14 of these 15 genes are involved in various aspects of cellular mitosis. And this fits the theory that for many immune cells in peripheral circulation, HIV initiates cell cycle entry, but mitosis is halted, and this leads to cell death. So our next analysis was designed to test the accuracy of our gene expression signature using random forest. This type of analysis differs from the differential gene expression, as it uses the entire expression dataset to classify each sample as either chronic with or without ART or acute infection based on gene expression. And then this was compared against the true classifications. Included in this analysis, we defined any sample collected within the first 3 months as acute. The rightmost column contains our 47 acute samples, with 40 being accurately identified as acute, and the bottom row contains 52 samples that our signature classified as acute. So there are 12 misclassifications, with 10 of those being chronic untreated infection, which is the major recurring issue for incidence assays, and it's even difficult to distinguish at the transcriptomic level. Overall, our full gene expression dataset accurately classified 74% of samples for the 3-month time point. And work is now underway to refine this signature with the aim to limit the number of genes required, as well as improve accuracy. So in conclusion, this cohort has provided a unique opportunity to study the first 18 months of HIV infection, and in particular has enabled greater understanding of the acute and early stages of infection. RNA-seq is now the gold standard of transcriptomic technologies, and application of this methodology to people living with HIV may greatly increase the knowledge of the underlying mechanisms of HIV. The stabilisation of differentially expressed genes between acute and untreated chronic infection by the 4-month follow-up time visit occurred months prior to our cohort reaching viral set point at 6 months. And furthermore, we have identified 15 differentially expressed genes unique to acute HIV, which may be useful in future incidence assay optimisation. We have also identified a gene expression signature unique to early HIV infection, most effective at distinguishing the initial 3 months from longer-term infections. I would like to acknowledge the many people involved in this study, which has been a truly international collaboration. In particular, I would like to mention Denise Danish, the primary investigator of the project, and Ignacio Mando, who led the team in Manisa, and Erica Parker and Peter LeSuef, my colleagues in Australia. I would like to also acknowledge our funder. Thank you.
Thank you very much. Could we have some questions?
Hi, Sally Hodder, West Virginia. Thank you. A very nice presentation. There have been algorithms that have been, designed, created to try to define acute infection, and they have used a variety of things, CD4 count, antibody levels. How does your, sort of using the RNA-seq compare to those algorithms? Question one. And question two is, do you see using RNA-seq as a part and developing new algorithms?
Good question. I think that using RNA-seq, it may become a part of developing new algorithms because it may identify new targets. And sorry, can you please repeat the first part of your question?
Sorry, yeah, how does your RNA-seq compare to the existing algorithms? You had about 74% correctly identified.
Existing algorithms do perform a little bit better, I think, than ours. But this is our first level of analysis, and we need to further work on this and refine this, because included in our signature is the full gene expression data set, which is 17,500 genes, and Random Forest gives those genes importance and classifies accordingly. So we think that if we can reduce this, we may have better classifications. So that's what we're working on now.
Yes?
Thank you, Ricardo Mendizal from Guatemala. Quick question: these genes are dependent from the HIV subtype or group, or are like general, or was only like some group M only infections?
All of our samples were subtype C.
Okay.
So that's all. Yeah.
Thank you.
Thank you.
Here and then here. Sorry. And is there someone at the back there? No. Okay. Sorry. Go ahead.
I didn't follow, maybe I didn't see your control sequences. You had HIV negatives, but did you include any other causes of acute febrile illness in your area, malaria or anything else?
So people presented to the hospital with febrile illness. So the ones that tested negative, we did ask a subset of those to return 1 month after, so their febrile illness should have cleared by then. But, so we tried to exclude anything that wasn't acute HIV. So we excluded pregnancy, we excluded malaria, we excluded other illness, yes.
I guess the question I'm asking is, have you compared your signature to the signature in response to any other cause of febrile illness that is common there? So, is there anything that distinguishes HIV, acute HIV infection, from other causes through your signature?
We haven't done that with our cohort, but what we've looked at is we've looked at other studies of acute infection and compared our most acute time point to see the level of dysregulation at that time point, and we found for HIV compared to influenza and rotavirus and Salmonella, Shigella, dengue, that the acute HIV reaction is larger by up to 4 times. Yeah. Thank you.
Thank you. Over here.
Good morning, Stephen Delgado from ICAP at Columbia. Thank you for the nice presentation. I missed the point. Were all of the acute infections ART naive?
Yes. All ART initiation was a cause for withdrawal from the acute cohort.
Okay, so as we move more and more into the test and treat paradigm, will you see, or do you anticipate that you'll see that differential gene expression in recent ART-treated infections versus the chronic ART-treated or ART-naive infections?
Well, we were surprised that the differential gene expression between treated chronic, the group was so different, so sustained and so different. So we do expect to see differences. But I think in the context of our study site, a lot of people still have infection for quite some time before they do present for testing. So yeah, I think there will be changes as test and treat becomes more integrated, yes.
Okay, thanks.
Thank you.
Thank you very much, Melinda.
Thank you.
Our next speaker is Alea Khalifa. She's an HIV epidemiologist at UNICEF. She works in the data and analytics section within a division of data research and policy, where her main role is to measure global progress in the HIV response for children and adolescents.
All right, thank you. All right, I just want to say thanks to the previous presenters. I think those are all really important implications and insights for different pockets and drivers of the epidemic, and I hope in my presentation I'll give a global view and perspective on the pandemic at large. So thanks again. So we're going to talk about demographic transitions and the future of the HIV epidemic for children and adolescents. So today, well, the world has committed to ending AIDS by 2030 as a public health threat. In order to achieve this, UNAIDS created the Fast Track Strategy. It consists of treatment coverage goals in the 390s and later the 395s cascade, and it also calls for a dramatic reduction in new HIV infections among adults 15 and above. However, demographic shifts among children and adolescents under the age of 20 could threaten the progress towards these global goals. This chart shows the child population under 20 from 2010 to 2050, which will increase across the world from 2.4 billion to 2.6 billion in 2050. But the greatest rise is projected for sub-Saharan Africa, from about 500 million children today to 960 million in 2050. This region is also home to over 80% of child and adolescent HIV infections, which is the rationale for this modeling. So our overall purpose is really to provoke conversation around planning for future generations affected by HIV, but specifically we aim to project the epidemic for this age group until 2050 and to understand the effect of demographic and epidemic trends on region-specific projections. And also, finally, to quantify the potential impact of meeting fast-track targets on children and adolescents by 2030, but also beyond 2030. So before we dive in, it's important to understand Spectrum software and the AIDS impact model. This is a country-driven activity that occurs annually. The data are also validated and compiled by UNAIDS and their global partners. Each year, there are regular improvements made to the software itself, developed by Avenir Health. So thank you to Avenir Health. And assumptions used in the model, which is informed by the newest empirical evidence, such as what you see at this conference and an expert reference group. At its most basic form, it uses demographic and epidemiologic and programmatic data on HIV, and output include various indicators of the HIV epidemic used to monitor the response up until 5 years into the future. So in this modeling, we used the Spectrum 2017 file, so it projects until 2021. However, since we wanted to project forward, we reprogrammed the model to project forward to 2050. So about every year, about 160 country files are updated with data, and we chose to exclude any country files that did not have any historical incidence data to really reduce the uncertainty around projected incidence. So we arrived at a final set of 141 country files. And in terms of representation among the general population and among the population living with HIV, for children and adults, it represented over 95% of those populations. So we then used these country files to implement 2 epidemic scenarios. The first scenario is based on current trends of HIV incidence, ART coverage, and PMTCT coverage. So we took 5-year modeled trends, or 5-year trends, and modeled into the future on a log linear curve. Now, the fast track scenario assumes a linear scale up of ART and PMTCT coverage to those global goals. So, for example, ART coverage is expected to achieve 81% coverage in 2020 and 90% in 2030. We added on the PMTCT coverage assumption to achieve 75% coverage by 2020 and 95% by 2026. And HIV incidence was extrapolated into the future to hit that goal of adult HIV infections in 2020 and 2030. So we focused on a few key output just to focus the results of our 2 scenarios. These are new HIV infections among children under 5 and among adolescents 15 to 19, and then also the total number of children aged 0 to 19 living with HIV. In Spectrum, we assume that very, very few infections occur between the ages of 5 and 14. And so these results were all extracted at the country level, but we aggregated to the regional and global level to get a view of the pandemic. And then we disaggregated by age and sex where relevant. So this slide shows the first results of our analysis. This is in the current trend scenario, and showing new HIV infections among children under 5 in blue and adolescents aged 15 to 19 in orange. And the lines show the HIV incidence. So this is what we're projecting given current trends until 2050. In blue, you can see the number of new infections among children is actually expected to decrease by half before 2030. However, for adolescents, it likely won't decrease by half until 2050. And in terms of incidence, we see a projected average rate of 2% decline in children under 5, but only 1% decline among adolescents. And since incidence and infections are projected to decline faster among children than adolescents, over time, adolescents will experience a larger and larger share of the burden of new HIV infections for young populations. Here we show the number of children, adolescents, and adults living with HIV from 2016 to 2050 in the current trends scenario. So by 2030, there will be about 680,000 children in the blue living with HIV and 1.2 million adolescents. This adds up to about 1.9 million children and adolescents under 20 living with HIV in 2030. By 2050, we see that it could decline to under 1 million for that age group. But now note the pattern and also just the different y-axis for adults, because we're looking at the pattern here. But children living with HIV has been steadily declining and will continue to do so. For adolescents, we start to see the same decline over the next decade. But what becomes clear is that many of these children and adolescents are aging into older age groups and thus sustaining the total number of adults living with HIV into the future. So in 2016, there were about 34 million adults living with HIV, and in 2050, we project 36 million, given current trends. So now we go into the regional differences. This chart shows the percent distribution of new HIV infections among children and adolescents combined by geographic region, or not combined. The top graph shows 0 to 4, and the bottom graph shows 15 to 19. In previous years, about half of all infections occurred in Eastern and Southern Africa and about 25 to 30% in West and Central Africa. However, because of recent trends in each of those regions, we see that by 2050, West and Central Africa will contribute more and more to the global epidemic relatively. And so by 2050, about 48% of new infections among children and 35% of new infections among adolescents will happen in West and Central Africa, which will both be greater than Eastern and Southern. Other notable changes in the chart below for adolescents are projected relative increases in Latin America and the Caribbean, seen in dark green, and Eastern Europe and Central Asia, seen in pink. And really, just as infections decline in Eastern and Southern Africa, these are signals of a globalizing epidemic for adolescents. So this chart shows the number of new HIV infections among children and adolescents by sex and at each decade. The labels show the percent decline since 2010, since that's when we set these global targets. The red bars represent the projected current trend scenario, while the blue bars represent the fast track scenario. In the current trend scenario, greater reductions are projected for children under 5, and among adolescents, we expect to see greater percent declines in infections among girls compared to boys, although girls will still contribute more to the global number of HIV infections. Now look at the blue bars. If we meet fast-track goals, we could inch a little bit closer to reducing new HIV infections. Among all child and adolescent groups, new HIV infections could decline by at least 75% by 2030 just by meeting those 95, 95, 95 and incidence reduction goals. So our findings really demonstrate the need for child and adolescent-specific targets, and so that's what we aim to model next in our third scenario, but also the need for resources to meet those targets. So the good news is we already have the 3 Frees framework, which aims to achieve an AIDS-free generation. The bad news is we are far from reaching the 2020 goals listed in that framework. So Start Free calls for a 95% reduction in new infections among children under 5. In our current trend scenario, we only project a 42% reduction. In the fast track scenario, we only project a 49% reduction. Stay Free calls for 75% reduction in new infections among adolescents. In our current trend scenario, we only project a 28% reduction in girls and 25% in boys. I'll just rush ahead. Finally, our results illustrate also the concept of aging populations living with HIV from childhood to adulthood. This aging concept can be understood from 3 factors in our predictive model. These are increased survival, steady flow of new HIV infections, population growth in certain regions, especially the ones with persistent HIV incidence rates. And these 3 factors vary by region and thus influence the regional epidemics in different ways. So next steps for improvement in the model, we will update with the Spectrum 2018 model, which was used this year, and also that will help to fill certain knowledge gaps, for example, in retention rates, HIV transmission, especially incident infections during pregnancy and breastfeeding. And then we'll also model those child and adolescent-specific targets to see if that's enough to curb the epidemic. And these results can also help for further analysis and better public health action, such as economic impact, forecasting, and country-specific projections to start more local dialogues. So thank you. I want to say thank you to UNAIDS and Avenir Health for making the modeling possible, especially Mary Mahey and John Stover, and also the National HIV Estimates teams, which worked so hard to make these models, and the Ministries of Health who lend the data to model these epidemics. So thank you.
Thank you. Are there any questions? Oh, yes, one over there.
Hi, Lee Johnson from University of Cape Town. Thanks for the really interesting analysis. I was interested in the results that you presented showing an increasing fraction of infections occurring in West Africa. Could you clarify, is that due to the very high TFRs that are projected for the Western African region, or is it because the assumptions about the kind of epidemiology of HIV in West Africa is very different from elsewhere?
It's actually a combination of factors. First of all, that child population is expected to increase at a really quick rate in West and Central Africa, and combined with really slow reductions in HIV incidence and really slow scale-up of PMTCT coverage, all of those factors converge to create kind of a bleak picture. And I mean, you know, we can avoid it if we act fast, so it really just serves as a warning.
One more question, or? Okay, thank you very much, Leah. Thank you.
Our last speaker is Gordon Ming, who is Chief Medical Officer for Blood. which is a social networking app for MSM with more than 40 million registered users worldwide. So, you will have the floor.
Sure. Thank you. Thank you, Wendell, for your kind introduction, and good afternoon, RAIS delegates. It's my great pleasure to be here to introduce some of our pilot studies, which is about how to use a social network app, namely Blood, to establish open cohorts to assess HIV incidence among SM in China. So, some background here, which is the MSM now is the most affected population by HIV/AIDS in China, and we know the prevalence, which is about 8% according to the National Sentinel surveillance data, and also we know the proportion, which is around a quarter of the diagnosed cases in 2017. But we don't know the incidence so far. It's quite a difficult one for us. As for the laboratory test, we have availability available, but there's a lot of restrictions to carry it out or scaled up in China. And also we set up a lot of cohorts in different cities in China, but still we don't have the national level, the incidence age. So we try to find, with these challenges, we try to find an innovative way to do some assessment in terms of incidence. That is why we generate this pilot. One more background is about Blood. Blood is a social network app for men who have sex with men. But last year, it already have more than 40 million registered users worldwide. And in China, it accounts for 77% of registered users in China. And in Beijing alone, it has more than 600,000 users. And which, according to our field survey, 89% of the MSM in Beijing, they use Blood, they are Blood users. So this gave us a very good base to measure HIV incidence. And also, when we look at their HIV testing habits, HIV testing behaviors, which is about the repeated HIV testing proportion is nearly half. So this can generate a new methodology to set up an open cohort for that. So we do that last year, and we combined online and offline services in a platform. Online services will provide HIV testing promotion and health information delivery with new media tools, a matrix I will talk later. And also we set up online HIV testing booking system and the electronic informed consent and the online questionnaire to collect some information based on that. And also we operate 4 HIV testing sites across the Beijing city. So we combine the online and offline together to set up open cohort. So this is the matrix we promote HIV testing and to deliver information. We use private method, which is the point-to-point, and we can send out the text message to all of our users in Beijing city. And also, we developed 13 splash screen ads, which will stay in the screen for about 3 to 5 seconds once you open the app. So it gives us another channel to deliver the information. And also, we developed banners, and we use opinion discussion, which is very similar as the BBS, the qualitative information collection tool. And also we use live stream. We invited several expertise to give us a live show online to introduce the window and Windows period and also some testing kits. So we use this kind of matrix to do the HIV testing promotion. And based on that, we also embed the testing booking system in Blood, which is very novel, and you can not only enter this platform through Bluetooth. You can also enter this platform through other channels. For instance, WeChat, which is very popular in China, and also you can use microblog to enter this platform. And also, this platform we recommended all the users of the Bluetooth in Beijing will be recommended to their recommend to the testing venues close to their location, because there's a GPS function inside. And also we do online informed consent and mobile verification for that. After that, we will collect information anonymously, which is including some behavioral information and the demographics information. Once they finish this online questionnaire, there will be a notice sent to their mobile phone to let them know they are successfully booked the HIV test services. So this is implementation of our pilot study. It's from last year, June last year, until March this year. And all the users who tested more than once have their testing record linked automatically by Bluetooth ID and a mobile number. And the time intervals between tests are captured, which will be used for our data analysis. And attendance with reactive results will be referred to local CDC. According to Chinese regulation, as only the confirmatory testing can be done by the CDC or by qualified hospitals. We couldn't do that. So what we are doing is to do screening test. So once the people found it reactive, we will refer them to the local CDC for confirmatory and then for follow-up services. So because we are an internet company, so we are very cautious about the confidentiality protection. So we follow the Chinese regulation, which is the top level, level 3, the information protection level. It's required by the government. And also, we set up our own mechanism to do this pilot, which is de-identifying. So we set up data sets, which in this data set, you have Bluetooth UID and also some parameters of testing promotion. And also we generate a cross data set, which includes only 2 information, which is Bluetooth UID and the unique unique code. And in dataset 2, we removed all the Bluetooth UID we removed all the Bluetooth UID and only keep the unique codes and online booking records and behavioral information testing results. So through this mechanism, we de-identified our users' information. So this is the results for this pilot. And during our observation follow-up periods, about more than 4,000 HIV screen tests were taken, and among them, 168 were HIV reactive. So we removed the HIV reactive person, and which left the rest number of follow-up is 3,598, and among them, 673 assessed HIV testing again via Bluetooth. So this is for our analysis. This is included for our analysis of incidents. So during this period, 10 HIV seroconversion happened, observed, contributes in the total of observation period person years is 827, and we calculated incidence rate is 1.22 per 100 person years, which is very similar to the cohort operated by the Beijing CDC. In that cohort, they have around about 600 participants. But in this cohort, you can see we have more than 3,000 participants observed. So through these pilots, we recognized that use of social network APP provides us new methods for evaluating and monitoring HIV incidence, and which is much more cost-effective and real-time compared to our traditional epidemiological approaches, and which have a very good potential to scale up to monitor HIV incidence in China nationwide. Actually, we already covered 2 cities besides Beijing, which is Chengdu and Qingdao. So all the participants in this open cohort are already more than by the June, which is already more than 10,000 in this open cohort. And by the end of the year, we believe we will extend our open cohort to more than 20 cities in China, and we believe the whole participants will be more than 50,000. So that will be the largest one open cohort worldwide. We believe that. So this is the last. I want to thank all the Blue users in Beijing participating in these pilots, and the Department of Intervention, National Center for AIDS Prevention and Control, and Beijing CDC for their technical support. Thank you very much.
Thank you very much, Gordon, for this presentation. We have 3 minutes for questions. Yes, here.
Thank you. Kate Grabowski from Johns Hopkins University. Your follow-up rate was quite low, so I'm wondering what were the differences between the people who were followed up and the people who weren't? Can you talk a little bit about that? Thank you.
Yeah, thank you for your question. And because in China, we advocate all the MSM, they give repeated tests half a year. Every half a year. So because this follow-up, period is only from last June until this March. So because this study is still ongoing, and I believe by the end of the year, we will see the follow-up rate will come up. Because this is not a closed cohort, and this is open cohort, I think the follow-up rate will be increased.
Yeah, I'm just wondering, did you look at the demographics or the sexual behaviors between people who were followed and people who weren't?
Yeah, we compared that, the demographics. There's no differences between that. Thank you.
Next question.
Udi Davidovich from the Amsterdam Public Health Service. Thank you for this presentation. I understand that you could create a cohort only among those who agreed with the informed consent. I was just wondering how many people did not agree, and what kind of bias that introduces, you think?
Yes, as this is the pilot study, we gave the electronic informed consent online, and once they collect, they want to book these services, they can choose. If they accept that, we will put him in the cohort. Otherwise, we will just provide our routine HIV testing services to them.
And how many did not agree from your population, you think?
Very small amounts, less than 10% of them were refused in this cohort, because they really want to, once they join this cohort, they can check their historic testing testing history. Otherwise, they just know this time testing results. So most of them would like to join that because they will give them a whole medical record for their testing.
Thank you very much.
Thank you.
We're almost at time, but at this point we could probably take a couple of questions directed to anyone on the panel. Or we could all go to lunch. All right, so thank you very much to all of our speakers. I think it's been a really fascinating session. Thanks very much.